prevention tends to transfer resources from the poor to the wealthy, because it turns out people without many resources become ill and they need help, but they are getting crowded out by prevention for people of greater means. So all of this should have us question, why are we here? And are we here for risk, or are we here because people are suffering or ill?
Why are we here? It's a question that in general, I try not to spend too much time thinking about. But as you just heard from Steve Martin, a family physician in rural Massachusetts, it's a question that can get lost in the broader discourse on primary care. And what Steve's really asking is, what should primary care be? It's become very in vogue, at least in some policy circles, to say that ours is a sick care system rather than a true healthcare system. Health and Human Services Secretary Robert F. Kennedy Jr., for instance, often emphasizes that our healthcare system profits from keeping people sick and should instead focus on prevention, wellness, and the long-term health of all Americans. I mean, sure, but what is a healthcare system if not able to care for the sick? And is primary care, as it's being practiced right now in the U.S., optimized to do that? If I've learned anything in my reporting on primary care, it's that if you've seen one primary care practice, you've seen one primary care practice. Primary care in a rural Michigan independent practice looks a lot different than primary care in a large health system in the middle of a big city, and different models are shaking things up even more. Concierge and direct primary care practices, for instance, by virtue of having smaller patient panels and more physician autonomy, are often more accessible to patients. But despite this heterogeneity, one common lament I heard from a lot of primary care doctors, especially those practicing in large health systems, is that they're losing the ability to see their patients when they're sick. Dr. H is one internist I interviewed who asked to remain anonymous. When Dr. H began practicing primary care, the work was hard, but for all the right reasons. She diagnosed and treated a wide range of diseases, built long-term relationships with patients and families, and until the rise of hospitalists, cared for her patients in the hospital as well. In essence, she became the consummate internist, exactly what she signed up for. And as Dr. H told me, it was the best job in the world. But about 15 years after she started practicing, she joined a multi-specialty practice owned by a nonprofit foundation. And then everything started to change. The insults to primary care accumulated. Shorter visits, unmanageable inboxes, a staff exodus during the COVID pandemic. Like many PCPs, she adjusted to the squeeze by working more. Without staff support, she roomed patients, took their vitals, and scheduled tests and follow-up. When leadership threatened to cut physicians' vacation days if their documentation was late, Dr. H started spending hours at night charting, despite caring for a young child and a chronically ill husband. But one change Dr. H couldn't work around was the lost capacity to see her patients when they were sick. Forbidden from double booking to accommodate them, she often didn't hear about patients who needed her until after a centralized triage system had diverted those patients to urgent care. And so she started wondering, what does it even mean to be someone's doctor if you can't be there for them when they need you? I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. The insults to primary care have been well documented, so I don't want to belabor them. And the pragmatic consequences for patients who can't access their physicians when sick are quite obvious. But what I want to get at today is a subtler consequence. The loss of an archetype, the all-knowing generalist, the proverbial good doctor. Steve Martin, in addition to practicing family medicine, is an addiction medicine specialist and professor of family medicine and community health at UMass Medical School. And though Steve is well aware of the threats to primary care that are often discussed, he also has a perspective that I heard far less often. And that is that the focus on prevention and screening in primary care has not only crowded out care for the ill, but also encroached upon the skill set required to manage complex chronic disease. And so I asked Steve when he began to develop his somewhat unusual take. It began when Steve was a resident, and he received the book put out by the U.S. Preventive Services Task Force. The book outlines the physical exam and the many screening recommendations for which PCPs are held responsible. And as Steve dutifully tried to commit to memory these many tasks, as he meanwhile began to experience what actually happens in an exam room, something didn't sit right.
And this really prompted some deep questioning on my part over time as to what this physical was about, because virtually no one comes in for an annual physical with zero concerns and is just there to be screened and evaluated and risk profiled. Just about everyone has something on their mind or a concern they have or worry that they have. And one can pay attention to the patient's agenda, or one can map one's agenda onto the patient and essentially silence the patient during their visit. And this is a special visit for people. They're either in a high deductible health plan or they've taken off work for the day. It's a valuable set of time, and someone can go to their physical. If anything is done at the physical that has to do with anything surrounding a symptom, that becomes a cost to the patient. And if you have a high deductible plan, that could be a lot of money. And so we all face choices in primary care about what are we going to do for a patient or do anything. Are we going to adhere to this set of prevention guidance, or are we going to work with the patient's agenda? And I just feel like that tension alone between the medical agenda and the patient's agenda is in its most significant form in prevention.
Steve also pointed out how some of the measures to which clinicians are beholden can distract from actually being the patient's doctor.
We don't care if a patient feels better or not. We just imagine their blood pressure going from 141 systolic to 139 systolic, and then someone earns more money, but not if their blood pressure goes from 200 to 160. So every cut point sort of measure of quality, quote unquote, for these risk indices is illusory. And what you didn't learn from that is that the person's opioid use disorder or depression or breathing wasn't addressed because you cared so much about that blood pressure.
Wherever you come down on the value of preventive services or quality metrics, I think Steve's getting at a deeper tension between focusing on the health of the individual and working to improve the health of the population. And obviously, when the archetype of the good doctor arose, we knew so much less about how to keep people healthy. And because of that, the doctor could focus on the patient's agenda without shirking other responsibilities. And I do think we, as clinicians, should be responsible for a host of population health measures, whether it's blood pressure and diabetes management or cancer screening and vaccine administration. Because if not us, then who? But listening to Steve, I started wondering whether the mindset necessary to meet all of these measures is coming at a cost.
So an example that's jarring that is absolutely understandable is working with trainees, and I would have done the same thing, where they find out during the course of their visit that the patient they're working with is actually depressed and actively suicidal. And more than once in this situation, the patient may have come in for a physical. That's actually why they came in. You look at the chief complaint physical. What do you learn in the physical? You learn that the first thing on their mind that they spoke with you about, it wasn't screened in, was that they're concerned about their safety. And when in talking with the trainee about where we're going to go from here, one of the tensions they're feeling actively and explicitly is, can we get lipids for this patient? Can we get colon cancer screening scheduled? And what has happened is the power of regimentation and bureaucratization and standardization that we have been sort of in fealty to for decades now. It does work. It works in your brain. And it can really overcome the attention that any given person is seeking and deserves. Our attention has been captured by our training, has been captured by our quality metrics that are bizarre and sad. And it's harder for patients to capture our attention. The keyboard captures our attention, right? The screen captures our attention. The entire room is not built in 2025 to meet the needs of patients. And even when you're doing prevention, or especially when you're doing prevention, Qualitative interviews studies with patients are incredibly insightful and demoralizing because they end up in sort of tick box situations where they become very mechanistic and sort of inhuman, to the extent that a study in Health Affairs asked women who were screened for postpartum depression, what was your experience like? And one of the participants said, well, they checked a box, said I was depressed, and left the room. Because there's nothing, the screening is done, but actually helping someone isn't. And this has become even more farcical with social determinant of health screening, where we can check boxes that someone has a tenuous housing situation or is not able to make enough money for food security. No answers to that, really, but we screen for it. And it has become this proxy for actual action.
Steve's not saying that actual action isn't important. In fact, the first time we talked, Steve told me about a patient of his who'd recently lost his housing. A few days prior to our conversation, during Steve's vacation, Steve had visited the patient, bringing the patient clothes and food. But what Steve is getting at is some of the tough trade-offs that arise as the focus in the clinic shifts away from the treatment of disease. To be clear, I'm not convinced that clinicians, when they have a sick patient in front of them, are necessarily thinking about all the checkboxes that they face. The challenge, though, is getting that sick patient in front of the clinician in the first place. Steve talked about some of the opportunity costs of orienting primary care away from the treatment of the ill.
Because someone's here for a physical, I'm not taking care of someone with opioid use disorder. Because someone's here for physical, I'm not taking care of someone who has an immediate urgent infection. Because I'm here for a physical, someone who thinks they have COVID, I'm not able to take care of them. Or someone whose depression is much worse. Take your pick. All these things are not happening because I'm doing really marginal, if at all beneficial, prevention. What I'm struck by in our work is that it does not take many turns of the wheel of training until people forget what medicine used to be like. I wasn't around necessarily, but medicine prior to 1970, I was born in 1969, did not look like this because virtually all of what we're doing is based on risk factor and modeling. And it turns out all those screenings take time and have very marginal impact. What would be really profound would be being available when someone's sick. You could go into any given primary care office on any given day, and the majority of people may be there for asymptomatic reasons. They have risk factors. They have the risk factor of hypercholesterolemia. They have the risk factor of hypertension. And we don't have visits for people who actually can't breathe. That should be seen as a moral question as to why we've advocated care for the sick and embraced all too much care for the well. Because of the inverse care law from Julian Hart in 1971 Lancet, the proportion of medicine that someone needs is inverse to the proportion that you get. So if you have a lot of healthcare needs, the system doesn't tend to do very well for you. If you have relatively few needs, the system will invent them for you because you are a market for that system.
Because there are so many factors that have made it difficult for some primary care clinicians to tend to their sick patients, I can't draw a through line from a focus on screening and prevention to this access challenge. But once again, I think Steve's getting at something deeper about how we imagine what primary care should be, about why it matters to hold on to that conceptualization, and about the critical skill set we need primary care doctors to maintain to best serve our society.
People can't get a primary care visit. They're being asked to go to the ER or urgent care. In urgent care, they'll have no continuity and they'll have no definitive answer to their problem unless it's self-limited, which is the entire business model for urgent care and its venture capital funding. Or they'll go to the ER and wait who knows how long. And our colleagues there are on the front edge of a broken system. And I feel so much for our ER colleagues because they are open 24/7 and they're looking at the broken system coming to their door. Riddle me that, because I would say that access is actually a lagging indicator of this problem. Once you get to problems of access for primary care, you've run out of options. So the system has tried to accommodate in any other way, different kinds of colleagues, different kinds of training, different kinds of teams, take your pick. But now that's over, that's stretched. And there's no plan B of like magical new primary care happening. And so people are either going to get used to urgent care and ER and be sicker, and they'll forget what primary care could have been. because within a generation it could be gone. And even worse, I do a lot of addiction care. And for the last 25 years, and especially the last 20 since buprenorphine has been around, there's been a plea and an expectation that primary care would take on opioid use disorder care. It's not happened at scale, not nearly at the level needed. And it's not going to happen now that primary care is collapsing. I'll tell you that. And so do we have an epidemic of a life-threatening illness that should be in primary care, but can't get in primary care because primary care has too many things to do. And when you start to focus on prevention, what saddens me especially is the ethic that develops among newer colleagues or older colleagues of then lifestyle medicine becomes sort of the premium type of medicine. And people actually lose the ability to take care of complex illness, and that illness gets farmed out to other specialties, or they lose the ability to do certain procedures. And so what you're left with is a primary care that both has no time and has had its skill set removed, a skill set that should be around complex illness over time that's longitudinal, and patients know it.
Trainees know it too. And the more I talk to trainees, the more I realize that some would love to practice this type of primary care that demands this broad skill set and allows for longitudinal relationships. But exposure to this type of broad spectrum primary care is becoming more limited. And that's because large health systems, including those at many academic medical centers, increasingly treat primary care as a point of access and triage. Here's Bob Phillips, a family physician and executive director of the American Board of Family Medicine. Bob describes the competing interests between society and large health systems. It's in the best long-term interest of society to attract trainees to the primary care workforce who are seeking to develop and maintain a broad skill set. But given the immediate access challenges, the short-term interests of health systems and policymakers may result in a lot less enthusiasm for this type of holistic care. Here's Bob.
I think that with our trainees, it's really imperative that we help them see other settings where they can kind of have aha moments of, oh my gosh, this is what my practice could look like. There's a competing interest though, and that is a lot of health systems, as the primary care workforce is eroding and disappearing, are trying to find solutions, what I call easy buttons for access. And so policymakers, health system leaders who want access are starting to dumb down what primary care is. And dumb down can be a judgmental term. They're trying to reduce primary care to a more basic function than a fundamental function. And so they're trying to say a whole bunch of other people can do this function, and that is just going to drive physicians out of the workforce more.
One can understand the perspective of a medical student. Why spend thousands of dollars and 4 years of education to do a job many tell you can be done by either AI or someone with far less training?
And this job is sounding less and less interesting. I would much rather go do something else. And so I think I understand the political need for an easy button, but it actually could speed up the problem that they're experiencing by driving people out of that workforce.
Right. So it's like a self-fulfilling prophecy. We dumb
Absolutely.
it down. Nobody wants to do it. And then we lose more people when the whole point was to drive people into the profession to fill this need for access and care in the first place.
That's right. And we're losing nurse practitioners. We're losing physician assistants too. So the speeding up is not just about physicians leaving.
I want to know what it looks like to have dumbed down primary care. Like if I were to go to a primary care office, what would a visit look like in comparison to primary care that's not dumbed down? And let's just assume I'm 70 years old and I have hypertension and diabetes and some CKD developing, and maybe I'm having some exertional chest pain just because I have to throw in a little cardiology.
I think a basic level of primary care would be you need to go to the emergency room for that chest pain, or, I need to get you to a nephrologist. I need to get to a cardio. I'm really there just to help direct you into other services. And we know that model is far more expensive and more dangerous, frankly, because no one's integrating the care and seeing the person as a whole person. They don't have 10 years of knowledge to know that the 70-year-old has anxiety and has had bad anxiety and episodes of chest pain, which we've worked up and we recognize this again. Let's manage this person's anxiety as a means of controlling their chest pain. That's basic. I mean, in a comprehensive model, I'd be able to say, hey, I'm going to have you meet with our licensed clinical social worker, and we're going to work on your anxiety for the next 20 minutes. And then you're going to have a relationship with them to work on that. I'm going to hand you off in a warm handoff. Or I'm going to step out and go talk to the cardiologist who's embedded in our clinic and see if there's anything we should do right now in addition to that. I'm going to have a community health worker come to your house tomorrow to follow up on what we talk about today and make sure that you have the medications you need and that your appointments for mental health have been taken care of. So going from basic to comprehensive or fundamental is quite a shift. And I'll tell you, in my practice, when we brought in behavioral health workers and the system decided after 3 months that they weren't meeting their revenue targets and they weren't going to fund them any longer, my practice said, no, we're not going back. We will fund them. We now recognize the value of those warm handoffs, and we want that. So dumbing down or making basic is far less satisfactory for the patient, for the physician, and for their outcomes.
I don't think this so-called dumbing down or descaling is inevitable. But to reverse the trend, a few things are necessary. First, we just need to recognize where and when it's happening. And second, I think it's critical to point out the joy and gratification physicians experience when they're able to maintain a broad skill set. Here's Steve again on a patient of his who came in because she couldn't walk.
She had to go to the ER to get crutches. She works a full-time job in a retail setting. This is, really devastating. So first of all, what do? I text with my patients. So I don't use the portal because then the portal filters out people who have less social capital because you've got to get the portal. You've got to have a screen that works. I can't even go. I could go on and on about the portal. So the portal basically is a mechanism for allowing people greater means to generally interact with the system. So I love texting with patients. She texted me this, was able to have her come in the next time I was in clinic, which is in 2 or 3 days, talked with her about the crutches. So she had a terrible callus. That's what she had. And if anyone's had a callus right on their foot or a plantar wart and tried to walk on it, that is not a picnic. It's like, suturing a pebble to the bottom of your foot. It sucks. Back in the day, I was able to work with Jeff Habershaw, a preeminent, wonderful podiatrist. And Jeff taught me how to shave calluses and corns and work with nails. And I've been doing that ever since. It's not hard. And it was like a Lazarus-like moment for her. She put her weight on that foot and walked out, and it was beaming. And so sometimes it's just a marginal amount of training can bring patients incredible relief from their suffering, literally. So when it comes to procedures, I think that's where a lot of the joy may come from that you're describing, and helping someone with their reproductive health with IUD or an Nexplanon, and helping someone with a pigmented nevus that they're worried about that's really on their mind, helping people with an injection of their knee with cortisone because their osteoarthritis is so hard. I mean, these are just, pain relieving and suffering relieving options that procedures are in the service of and really are a gift.
I asked Steve whether part of the challenge, in terms of training clinicians who can maintain this broad skill set, is that academia tends to elevate the specialist over the generalist and the researcher over the clinician.
We have absolutely valorized research, likely at the expense of teaching and clinical care, which is also bizarre because, it's a medical school, but somehow being really good at medicine isn't really what's held up to be the goal of the school. The goal of the school is what's its proportion of NIH funding. What's made me more angry and frustrated has been someone who now has 1 session a week of clinical time and now expands on this idea that it's the most important day of their week. And they're just so glad to go to clinic. And isn't clinic really where all the rewards are? And tell it to someone with 9 sessions who's choking on the work. It's just such a self-selected group. And those self-selected groups tend to be academic leaders. So the more time you're in administration, the less time you're in clinic, the less time you're in clinic, the less empathy you have for people who are in clinic. And I think that is addressable, but we've had the hospital as a college, and now we have this lionizing of basic science research. And there have been remarkable things. You and I are now in the generation where we cure hepatitis C, which still shocks me. And I'm so grateful, where we developed a vaccine for COVID, where we are treating opioid use disorder, albeit with 50-year-old medications, but they cut mortality by more than half. Proton pump inhibitors, we're not doing stomach ulcer surgeries, which is one of the most common surgeries. So there's so many good things that have happened from basic science, but we are doing a disservice when we make the coin of the realm academic study and NIH grants.
The hepatitis C example was particularly striking to me, not only because it really highlights this disconnect between scientific breakthroughs and clinical care, but also because it reminds me of what primary care could actually be. So even though the ability to cure hepatitis C is one of the greatest scientific advances of the 21st century, CDC data suggests that only a third of those diagnosed with hepatitis C get treated in a timely manner. There are lots of reasons for this treatment gap, but access to care, and specifically specialty care, is part of the problem, which also means, as Steve pointed out, that primary care could be part of the solution. Steve described the work of Sanjeev Arora, a hepatologist in New Mexico, who recognized how infrequently patients with hepatitis C were actually getting treated. And Aurora also recognized that treatment was particularly difficult for prison inmates and underserved populations. Given challenges in accessing hepatitis C clinics, Aurora hypothesized that training primary care doctors to treat hepatitis C could improve this undertreatment. To test his hypothesis, Aurora started something called Project Echo, which used telehealth and video conferencing technology to train clinicians at community health centers to treat hepatitis C. And Project Echo worked. Aurora and his team published their results in 2011 in the New England Journal, and they showed that patients treated in communities by Echo-trained clinicians had similar rates of sustained treatment response to those patients treated at academic medical centers. Here's Steve reflecting on the results and a vision for primary care that would allow more upskilling and less specialist dependence.
Dr. Arora is one of the few hepatologists at the University of New Mexico trained primary care clinicians in the field to use at that time interferon for hepatitis C cure. He had waits of 6 months to see him. And that wasn't even to get treated. That was just for initial evaluation. And the New England Journal study found equivalence in cure rates between primary care and specialist care. But as Dr. Arora has mentioned, you can force multiply the primary care part, and you cannot force multiply often the specialist part. So he has now led hundreds and thousands of these echoes worldwide. Because of this, I learned from Cami Graham and Rachel Benson from the BI back in the day on how to treat people for hepatitis C through their Project Echo. And we've been doing that for the past 5 or 7 years or so with direct-acting antivirals. We've done our own echoes and provided them for opioid use disorder and for hepatitis C. And in doing this, you realize that where the system really falls apart is it does not fund people to learn more stuff. Right now, our hepatology clinic is 6 to 9 months away. I don't know what proportion of that is for hepatitis C, what proportion of that is for alcohol-induced hepatitis, but both of those things can be done really well in primary care and should be, I'd argue. You could do outpatient withdrawal for alcohol in primary care for 80% of people who are drinking. I could go on and on. So all these things are possible in primary care, but you know what I wouldn't be doing? I wouldn't be asking someone about whatever prevention test, take your pick. I wouldn't be doing that. And I would let some other entity do that if it's so important. But you know what? You don't have to go to medical school to do that. I did not go through training to do that. And you don't need someone like me to do that. So why are we doing it that way? Instead, I would love to be helping that person with the complex issues we just mentioned. I hope that gives you a sense of like the real, I mean, I get texts all the time. I didn't drink since January 6th, right? Who doesn't love a text like that? I just bought a house. This is a patient I've been with for 15 years who's been through hell with all sorts of mental health and social and addiction. She just bought a house.
That's
I mean,
amazing.
I can't even tell you. I want to take screenshots of every one of these. And I do. And I'm choking up here because that's the work. But primary care is not taking on any of these difficult, complex things because it has been somehow reconfigured as the method of prevention for the country, which is just a tragedy and a travesty rolled up in a big shit sandwich.
I'm not ready to abandon prevention. But as we move toward team-based care, I do think there are important questions to be asked about what services should be provided and by whom. And to be clear, some patients are unwilling to undergo recommended preventive tests unless they speak to a clinician they trust. A friend who's a PCP, for instance, told me about a patient of his who wouldn't get a colonoscopy until my friend, the PCP, had explained to the patient all of the risks and benefits. But part of earning that trust involves being there for patients in the first place. Sometimes that's for prevention, sometimes it's for illness, and sometimes it means modifying care in a way that takes into consideration all of the patient's other needs. I think, in its foundational form, that's what primary care really means. And so I wanted to end with this example of what primary care doctors can do for their patients, if we let them. Here's Renee Critchlow, a family physician and CEO of Codman Square Health Center in Boston. Renee is remembering a patient she treated early on in her career.
When I was practicing in Montana, one of the towns I practiced in was a town of about 900 people. And I remember one day, I was, relatively early in my career. And I had one of my old rancher guys. I checked him. I was listening. After I listened to his lungs and checked his labs, I was like, "Sir, you're in congestive heart failure. We're going to have to get you to the hospital." And I was starting to, write down all the stuff that I needed to do, get the orders in. And as I'm doing that, he's like, "No, we're not going to do that." And I was like, "What do you mean we're not going to do that? You have congestive heart failure. I need to put you in the hospital." He's like, "Doc, I can't do that. I can't go to the hospital. I can't have you put me in the hospital. If you do that, I'm going to lose my ranch." And I was stunned because, I was a young doc. I knew that when someone's in CHS exacerbation, you take him to the hospital. But he had pointed out to me that there are consequences for him going into the hospital to the level of losing both his livelihood and his home. And, I knew that what he thought of as his ranch was, a small farm. It wasn't any big fancy ranch, but it was his livelihood and it was his home. And he was uninsured. This was before the Medicaid expansion in Montana. And he was like, "Yeah, no, doc, I can't do it. What would you do in that hospital?" And I said, "Well, we would take your blood levels and draw your labs, and we would monitor you every day with your weight, and we would diurese you, so we'd have to monitor the fluid that went in and out." And he's like, "Okay, well, you can do that here." I was like, whoa. I don't know that we can do that here. He goes, "Well, I trust you, doc. I think you can do this." And I gotta say that having that man put that kind of trust in me, knowing that his livelihood and his home depended on us doing it, yeah, we stepped up and we did it. But it was a real eye-opener. It's like sometimes you have to walk this high-risk thing, and he was walking that high risk whether he went into the hospital or not. And his biggest factor in our ability to care for that man in a way that he did not lose his home was him trusting us and us trusting each other to do the work.
For patients, losing access to this type of holistic care clearly threatens more than just their health. But what does narrowing the scope of primary care mean for doctors? For Dr. H, the physician I told you about at the beginning, being unable to practice as the consummate internist proved intolerable. So she left. Dr. H joined a concierge practice, and now many other physicians are doing the same.
And so patients really that's what they're looking for. They're looking for somebody who knows them, who cares about them, who's invested in them. They want to get to know me. I mean, my patients want to ask me, do you have kids? Do you go through menopause? Did you, whatever it might be, right? We're all just human beings who are trying to connect with each other and trying to feel like somebody is looking out for them.
That's next up on Not Otherwise Specified from the New England Journal of Medicine. I'm Lisa Rosenbaum. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My article series on primary care can be found at nejm.org, and our email is nos@nejm.org. I'd love to hear from you.